So,
screen. Okay.
Yeah. Please go ahead with your presentation.
Yeah, thank you very much for this opportunity. It's a big honor for me to speak in this forum because which is very close to my heart, the research and innovations. So I'll be speaking what innovations happening in orbital surgery and how I am involved in it. So the four major innovations in orbital surgery are basically one is the 3D printing, second is the navigation guidance, the third is the robotic surgery, and the fourth is the AR and the VR, which is really something which is making a big change in orbital surgery. So what I want to insist that I'll just start with the 3D printing and the navigation that we are being doing at Sri Shankardev Netralaya. So 3D printing, I'm using it extensively for the customized reconstruction, especially when there's a fracture of the orbital walls. And these orbital walls, which a very severe fracture involving both the vertical matrices and the horizontal matrix, as you can see here, the whole of the eyeball is being involved, and especially when there is impure fracture, the fracture involving the orbital rim, the fracture involving the multiple walls leading to a comminuted fracture. So these are the situation where we do need to use a 3D printing, which helps to realign the buttress, release the entrapment, and reconstruct and reform the fractured orbital walls. So what is this 3D printing? This 3D printing is basically we have a 2D image in the DICOM format, and then this is being followed by conversion to the 3D images, where we take the CT scan in different forms and we convert it into 3D images in all 360 degree once we view it. And these 3D images are now next converted to 3D modeling and then exported into the surface tessellation format. And from this surface tessellation format, we get the 3D printing. So in situation like this, when you have a big fracture involving the NOE, the supraorbital rim, the infraorbital rim, the pan fracture, this navigation will not help. This is where the 3D really comes into play. And these are some of the images of the 3D reconstruction that I have been using as Sri Shankara Deva Netralaya with the orbital fracture, where the application is not only for the fracture, but also it is used as an education tool and also in the management of the anophthalmic socket. Like situation like this child, when he comes to me, it's such a bad situation. You can see the whole of the eyeball is being subluxated down. There's a canthal dystopia and there's a fracture medial and the inferior wall. And once you see the 3D pictures, and this is how it has really helped us in navigating along with doing a 3D reconstruction. So once I was doing the navigation, this is how we do a mirroring. I'll come to you later. I have measured, this is the normal, the blue is the normal orbit. Other one is a blowout orbit following a fracture. And then once you measure that how much amount of reconstruction is required, and then once you go ahead with the surgery and you put the appropriate amount of volume, which is usually measured with the navigation system and also with the 3D remodeling that we have, and then you can get a very appropriate correction. And this is how the child looks after approximately a week, and this is how he looks after approximately a month. So along with these fractures, it is also very much useful for the contracted socket, especially in situation like this, where you really need to do a 3D printing and see how much amount of contracture, and you see there's difference of at least 10 millimeter in both the socket. And this is a difficult situation because this patient has undergone multiple operation in multiple parts of the country, and he does not have the inferior orbital wall, and he does not have any of the socket tissue. So you need to give the socket tissue, you need to form the infraorbital wall. And now because you have a 3D system where you know that there's so much of contracture, I have devised a very innovative surgery. What I have done, I have cut the whole of the inferior maxillary wall and rotated it anteriorly so that this has given some volume to the socket and made this socket deep. So once you have measured that how much amount of socket contracture is there, you also need to plan that how much amount of volume you'll give, and this will not help with the graph. You need a flap which has a blood supply to it, and the best is a temporalis muscle. So this is what you can see. Yeah, almost. So this is what you can see how we had to cut the whole of the maxilla, and the maxilla is then rotated anteriorly along with the temporalis muscle transfer, and somehow you can end up giving him a good prosthesis. So in many situations, I also say the cutting edge technology is navigation in many situations, which is basically a GPS system where all the data you have in the CD, it can be a CT, it can be MRA, it can be MRI, and then you incorporate it into the console, and this console helps you do a surgery in very complex complex situation, especially in the optic canal region or in the superior orbital fissure. And you know, this is very difficult, hard to reach area. And these are often being fractured by a shearing force. Also, it may be fractured by also multiple commutative fracture, as you can see here. So navigation is one of the technology which has helped us not only the mirroring and going for a very good reconstruction in cases of a fracture, but also it has also helped us to do challenging situation like optic neuropathy. Just one slide, I'll show you.
Please, take your time.
I can take, then let me show you this. Like, this is a situation, see, this is so challenging. When you have something like a fracture in the frontal bone, it's very difficult. We don't want to go, because when the frontal sinus bleeds, it bleeds so profusely, it can lead to anything on the table. But as because I have the navigation, see, I can guide, I have drawn, this is the plane, how do I enter? And with very minimal manipulation, I can go and reach to this frontal bone, which is the whole of the foreign body. This is a big palette, and with very, very minimal manipulation, because I have drawn the whole of the cylinder, the pathway, how do I enter, and this has helped me to remove the foreign body somewhere very near to the brain. And another important thing I would like to show, see, this is a traumatic optic neuropathy. I was doing the decompression. See, when I put my stylet, my navigation stylet is not entering the optic canal. So this shows, this is guiding me that my surgery is not complete. So what I need to do, you can see in the sagittal, see, it has not reached the roof. So I have gone for further decompression. I went down to the optic canal, and I had de-roofed the superior orbital wall. And now once you see now I'm placing my navigation stylet in the actually, you can see from the orbital to the cranial part, in the coronal also you can see this going to the roof of the optic canal, and also in the sagittal you can see very well. So these are some of the technological advances and the innovation, and I feel without this you cannot take up the challenging situations. Thank you very much for your patient hearing.
Thank you, Dr. Kasturi. Anybody in the panel would like to ask a question? We have some time, so if somebody wants to ask, we have time till 6:25 for the session. So, Dr. Kasturi, John, you are into 3D printing. John, are you still around?
Yes, sir. Yes, I am. Yes, sir.
So, Kasturi, I'll kick off a question, and then maybe John. What material are you using? Thermoplastic, of course. So, what material are you using for orbital reconstruction?
No, there are different ways. Actually, what we do, we give the diacom. It is not I'm doing. There's a person from IIT Guwahati. They actually do it for us. We just give them CT, and sometimes they can customize it. The same biopore implant that we are using, they can have a fragmentation. They do a auto segmentation, and they can customize it. How much amount of thickness that we need to create.
No, what I'm asking is what biocompatible material are you using? Because you're going to leave that.
That's yeah.
What's it?
Polypropylene.
Polypropylene. Okay. PP. Okay. Yeah. So that's fine. So John, you have a question?
I'm interested in 3D printing. I did a little bit of 3D printing. I didn't want to put anything into the human body because I was not sure of the biocompatibility issues. So most of what I've done is things which don't go into the body. But the OMFS department here in Ramchandra Medical College, they are trying to get into this. I think they would love to get in touch with you. I would definitely recommend, I'll tell them to contact you.
It will be wonderful. You know, we really want the customized implant, which we are not getting. We are getting the 3D skull, but to have a customized implant, which is accepted by the body, and the same material, the medport, that is polypropylene, if we can use it, it will really help us because it gives a very good tissue integration.
John, you can't be saying that you're scared of putting in a 3D printed material. People are having a beating heart 3D printed now. So I think we are not very far from that. So.
The printers which I have access to are all
Not
PLA.
a tissue printer.
I have a resin printer which is quite toxic. So I'm putting everything in Model Eyes and
I know.
for now.
I know. I don't
have the bio printer.